Over to you, sir.
Thank you. Thank you. Welcome to all of you. This is my first time. I must at the outset, um, you know, commend the effort taken by the national board to, organize such an event where, candidates get to hear from, you know, experiences of various doctors across specialties across the country. And I hope this initiative continues for the future batches also. So without much ado, um, I would like to kind of like highlight about parathyroid glands. Now, when we talk about ENT doctors, we treat what we see. If we are seeing polyps, if we see a perforation in thyroid surgeries or head and neck cancers, we are able to see a swelling, ulcer, mass. But in parathyroid glands, what we have to evaluate, as rightly mentioned by the name of the topic, is the functioning of the gland and treat it accordingly. So if we don't know what we are treating, then we will not know what to look for, where to look for, and more importantly, or most importantly, when to look for it. Okay. So I'll start simply by a clinical history. I have a 67-year-old lady who presented to me with so I treat sleep apnea. So she came to me with some sleep issues. She was having a lot of fatigue, bone and muscle pains. You would think about usual 67-year-old lady stuff, uh, not unusual in that age group. However, what I noticed is that lady was getting her annual health checkup done annually, regularly, and for the past 2 years, her calcium levels were elevated. She was also having obesity, diabetes, high blood pressure. You can see the number of comorbidities. However, the standard bones, which are pathological fractures or such obvious history wasn't there, which is very commonly seen in hyperparathyroidism. Now, when we talk about parathyroid glands, classically, if you see the textbook pictures, this is how they are shown. The first time somebody suspected them to be abnormal, von Recklinghausen, the reputed pathologist, thought of them as lymph node in the neck below the thyroid glands because they were obviously enlarged in that patient who was having frank hyperparathyroidism, that is leading to changes in the bones. And then when total thyroidectomy became a norm, people started correlating the calcium levels with parathyroid glands. And the first parathyroid surgery to relieve bone recurrence or bone pain rather was done in 1925 by Mandel in Germany, and the patient remained recurrence free for 31 years. So essentially, this is when and how the thought process or the science behind parathyroid glands became known. Now, as we all know from our anatomy classes, that parathyroid glands kind of like originate from two different structures. From the third brachial pouch, you will have the parathyroid 3, and from the fourth brachial pouch, you will have the parathyroid 4. Okay, so this is the parathyroid 4. Now, what is unique about parathyroids is the parathyroid 4, if you look here, actually don't migrate a lot. Whereas the parathyroid 3, along with the thyrothymic tract, they get descended lower down. So, as a clinician, how does it matter to us? Is when we are looking for parathyroid, the superior ones are more or less constant in their location and very predictable. Whereas the inferior one can be very variable in their location because of their embryology. They may get pulled down, they may go as down as superior and anterior mediastinum. Typically, the superior parathyroids are more predictable in location. Now, coming to the physiology, which is very important in dealing with parathyroid glands. The most important function or the trigger of the parathyroid gland is the calcium level in the extracellular fluid. As we all know from our physiology classes, that reduced in calcium level is the biggest trigger for increased parathyroid hormone production. Now, parathyroid, once stimulated, primarily will lead to increase. See, all that parathyroid is related to or concerned about is your free calcium levels in the blood. It is not concerned about the calcium levels in the bone, which is a storehouse of calcium, which stores, I would say, more than 90-95% of the calcium of the body. It is not concerned about the calcium levels in the cell, intracellular calcium, which is responsible for all the intracellular signaling. All it controls is the extracellular fluid calcium. Now, whenever the calcium levels in the extracellular fluid will go down. So typically somebody has got vitamin D deficiency and there is reduced calcium level overall in the body and the patient is having relative hypocalcemia. It will lead to a spike in parathyroid hormone levels and you will have what we call as secondary hyperparathyroidism. So when you do this blood test for this patient, you will find unnecessarily high parathyroid levels in the blood. But what is the reason? It's not primary. So high parathyroid hormone levels are abnormal only if by itself, if they are accompanied with high calcium levels. If the calcium levels are on the lower side, parathyroid hormone secretion is a compensatory effect. Similarly, increased parathyroid hormone will mobilize calcium from the bone by stimulating what is called as the osteoclast cells and also will increase reabsorption of calcium from the kidney through 1-alpha hydroxylase, which essentially is the enzyme responsible to convert 25 hydroxy vitamin D into 125 hydroxy vitamin D, which is the activated form of vitamin D, which will increase gut absorption of vitamin calcium, which will again help in storing up calcium levels in the blood. Drastically low calcium levels in the blood will lead to tetany and affect variety of our systemic functioning, including cardiac side effects. So so the body is definitely sensitive to it, and that's how the basic physiology works. Now, how do we apply this knowledge of physiology to us? Now, if I create a spectrum of parathyroid levels and a spectrum of calcium levels, as ENT doctors, we are concerned of one clinical condition, that is primary hyperparathyroidism. Primary hyperparathyroidism typically is the area where there is high calcium levels, typically between 11 and 13. This is too high. And parathyroid levels typically above. So normal parathyroid levels depend upon the assay that you are doing. The typical assay that we are doing has limits of 10 to 65. So typically you will get levels of 120 to 250, sometimes you may get 600. If you are getting levels above 1000, you should suspect parathyroid carcinoma, which is an exceedingly rare condition. Okay, so if you suspect something rare very often, we will be right very rarely. Okay, so secondary hyperparathyroidism, again you will find high parathyroid levels, but the patient is having multiple other medically treated problem. Primary hypoparathyroidism is seen typically after aggressive total thyroidectomy, and there is a PTH independent hypercalcemia. PTH levels are extremely low, but
there is either excessive intake of calcium with vitamin D. Just excessive calcium intake will never cause hypercalcemia in isolation. You need vitamin D taken along with it on a regular basis to increase absorption of calcium in the blood levels. These concepts, although we treat only this area, but we should be aware not to venture into this and refer it to our colleagues, or keep a high antenna for these conditions so that we can take help of our colleagues in treating challenging scenarios. So coming to primary hyperparathyroidism, which is essentially autonomous production of parathyroid hormone levels, which has inappropriately high serum calcium levels. Incidence of 5 in 1,000, that's not that uncommon. Most of them have single adenomas, meaning out of the 4 parathyroid glands, only one gland is involved. Some of them may have a double adenoma. Some of them may have a disease which is hyperplasia. Like I told you, parathyroid carcinoma is a very rare condition. Now coming to symptomatology. I know there are 4 parathyroid glands. However, I just need one of them to start malfunctioning in creating the classical clinical presentation of hyperparathyroidism. So you may have bones where there is essentially weakening of the bones. There is osteoporosis. Now this osteoporosis also follows a typical pattern. You will typically find that the distal end of the forearm will typically be the site where there will be maximum impact of this. You may find additionally some impact on the spine and the femoral neck. But the classical is the distal part of radius. Recently, I had a patient who had come to me for some other condition. She was telling me she recently got diagnosed with osteoporosis, a very young lady, 44-year-old, with no other comorbidities. I saw her DEXA scan. The orthopedic surgeon had seen her, had started her on osteophos. There are bisphosphonates and calcium and the usual. However, a premenopausal lady who is otherwise fit and fine, some antennas went up and I got her entire calcium workup done. Once the workup was done, I picked up hyperparathyroidism, which is a correctable cause, reversible cause of osteoporosis. So we could save the patient from lifelong of trouble. I've had patients who have had diagnosis of renal stones who have been operated on an yearly fashion for 7, 8 years before their hypercalcemia was diagnosed, before their hyperparathyroidism was diagnosed. You could have a lot of peptic ulcer disease, pancreatitis. Constipation actually is a very common symptom. Muscle weakness is another common symptom which we may attribute. And lethargy, weakness, joint pains are again something that, typically when you see patients of this age group, you may feel that, it is just age related. So again, you keep your antennas very high. If you're suspecting something, just get your calcium levels tested so that we can evaluate further. Now, the modern patient will come to us with incidentally detected hypercalcemia with all these free packages going around. A lot of these patients will be picked up sometimes even decades before they get diagnosed. So they are largely asymptomatic. And when you further investigate this patient, you may find osteoporosis, you may find nephrolithiasis, you may find neuropsychiatric or other musculoskeletal systems. You may find, rarely, this is an entity, not to confuse you guys, there is an entity called as, which is debatable in some circles, normocalcinic PHPT, where there is normal calcium, vitamin D levels are normal, but elevated parathyroid hormone levels, and they are generally detected when you're evaluating for osteoporosis and recurrent nephropathy. I've seen a few patients of this, but like I said, it's a little debatable entity because they are difficult to diagnose effectively. Now, there are other causes of hyper. Just a second. Right. So there are other causes of hypercalcemia where we need to suspect, and these are the causes. And typically, I will always take the help of my endocrinology colleague in evaluating them. these are the set of investigations that we order. Every investigation has a meaning, has a role when I'm evaluating the disease. See, as a surgeon, I am interested in diagnosing primary hyperparathyroidism. However, at the same time, we want to rule out others. So we order minimum of calcium, albumin, PTH, and 25 hydroxy vitamin D. This tells me the basic workup. Okay, ionized calcium is not routine. Okay, now when we look at this, is something that you can order if things look amiss. This is to rule out familial hypocalciuric hypercalcemia, where there is essentially a sensory issue where the urine is not excreting a lot of calcium and there is body is at a higher set level of calcium. It's a rare condition. DEXA scan comes after this. So once a patient comes to me, I will not order everything in one go. I'll first of all order the calcium, albumin, PTH, and the vitamin D levels. Make my diagnosis. If I'm suspecting primary, then I will continue the evaluation. If I'm not suspecting primary, then I will be referring this patient to an endocrinologist for evaluation. Once the diagnosis is made, then only then I do bone densitometry. This is only done when I am suspecting a syndromic presentation. Too young a presentation, other symptoms are available of multiple endocrine neoplasias. Then is when I suggest these conditions. Now, in patients who are young, who have possibly multi-gland disease, parathyroid carcinoma, or atypical adenoma, it is very important to get a family history to ascertain whether there are any first-degree family relatives who are affected or not. Now, once you have the levels, how do I diagnose? In primary hyperthyroidism, primary meaning we don't have other cause, the gland itself is enlarged. So you'll have increased calcium levels, increased PTH levels. If you get, so what does inappropriately normal mean? If I have a very high calcium levels, I should get suppressed PTH levels. My PTH levels should be in single integers. Phosphate levels will be low, normal. And there was a time when we used to do fractional calcium excretion. We don't do that routinely now, where we look at the fractional excretion of calcium was more than 1 to 2%. In secondary, like I told you, most common reason is low vitamin D. So you will get a low vitamin D level, which essentially leads to malabsorption, low to normal calcium levels, and a secondarily increased PTH level. Tertiary hyperparathyroidism is essentially seen in renal patients where both calcium levels are increased, PTH levels is increased. There is again the problem at the kidney level, which leads to high levels of these in the blood. Normal calcemic primary hyperparathyroidism we discussed. In FHH, which is familial hypocalciuric hypercalcemia, you get increased calcium levels, but inappropriately normal PTH level, very rare normal phosphate. These guys are essentially benign condition. You don't need to worry too much about it. But essentially, you should not go ahead and operate these guys because their calcium levels won't normalize by surgery. So this is where we are concerned, and that is what we are want to looking at. So going back to our patient, her calcium levels currently were 11.4, albumin levels were 3.4, and vitamin D levels were 24. So which is like borderline normal. Okay. Parathyroid levels were 4 times normal. USG didn't show any kidney stones, but her forearm T score, we all know what's a T score. T score less than minus 2.5 indicates osteoporosis. So specifically, when you're dealing with parathyroid patients, look for forearm DEXA scores. And the 42-year-old lady had a minus 3.9 in forearm that I was talking about, that I met a couple of days back. And the diagnosis was primary hyperparathyroidism. Now, if this was a class, I would have asked what is the concept of corrected calcium levels. So if you normalize the albumin level 3.4, so typically if you think of normal albumin level, healthy albumin levels of 4, then you deduce roughly, so her corrected calcium levels are even higher. So you have to compensate to look at how much is the ionic calcium levels, and her corrected calcium levels will be closer to 11.8 or 11.9. So this is definitely higher than normal. Normal being 8.5 to 10.5. Some authorities still believe that anything more than 10.2 should also be considered as abnormal. Now, coming to the treatment, you have a patient who's having symptoms of parathyroid issues, whose functioning is compromised, who's getting end organ damage. Now, you need to treat that patient. So what is the ideal medical therapy? It should be medical parathyroidectomy. Anything which will neutralize parathyroid hormone level. Such an agent would normalize calcium levels, PTH levels, urinary excretion, increase bone mineral density, and reduce the risk of kidney stones. There is no such agent available. You have different drugs available which can help you do that. You have hydrochlorothiazide, you have estrogen, you have raloxifene. The bisphosphonates will not change any of the calcium levels. They will just help in increasing the bone mineral density. Cinacalcet, which is like the antidote, will decrease calcium levels. So these are very useful, alendronate and cinacalcet, especially if you're dealing with a patient who's come to you with a hypercalcemic crisis. However, they are not the recommended treatment in any patient on an elective basis where you want to treat them. So these are the two drugs which will help you. Now, surgery is the only curative treatment and is recommended for those with symptoms and suggested for those with asymptomatic disease who are at risk of progression of or have subclinical evidence of end organ effects. So if I get patients who don't meet this criteria, okay, these are a standard consensus criteria which have been proposed to operate patients, especially those with asymptomatic. So any patient with any of these criteria, not all of these criteria, any of these criteria, you have to consider criteria for surgery. So if it is a young patient, if serum calcium levels is abnormally high, there is reduction in glomerular filtration, more than 400 milligrams of excretion, there is increased risk of stones, there is presence of stones, like I told you, T-score showing osteoporosis, presence of a vertebral fracture. So what we are trying to suggest here is, first, can we do assessment and find out if the patient is having any such significant issues. So ours is a 67-year-old patient who is essentially not less than 50 years, so this criteria is not met. However, her calcium level is more than 1 milligram over level. More importantly, she's got spine issues, osteoporosis issues in the forearm. Now, if I get, say, an 85-year-old, if I get a pregnant lady, these are not essentially, so it depends upon what is the medical condition. PHPT medical management essentially involves in delaying surgery and temporarily managing the hypercalcemia. However, if the patient comes in hypercalcemic crisis, you have to use a combination of bisphosphonates and cinacalcet with other medical therapies to reduce the serum calcium levels, which is best managed not by ENT doctors, frankly, but by a team of intensivists and nephrologists and endocrinologists. Our role typically comes in after the patient is stabilized, if the patient comes into crisis. However, that is very rare in today's day and age, at least in the the tier 1 city, kind of a Mumbai setting, a metro setting. Most of my patients come to me where either with kidney stones or with osteoporosis or other things. But the point I'm trying to make here is, first you should do the biochemistry, then do all of this. If the biochemistry is clean, you don't need to do DEXA scan. If the biochemistry is okay, you don't need to do any of these testing. So first is to test what are we treating, and then test why we need to. We don't need a CT scan for every patient who comes to us with high parathyroid levels. That should not be our approach. First, you decide, if I get an 87-year-old with marginally elevated calcium levels, with other comorbidities, with none of these issues significantly, then why would I want to pursue any treatment for something like a borderline elevated parathyroid levels? So you should find out that that what these patients are. And what studies have shown that if you follow up, only about 40% of patients will develop one or more indications of parathyroidectomy over a 15 years follow-up. So if I get a healthy 60-year-old, I am not going to not do anything about it. But if I get a person who's 65-year-old, having end-stage cancer, having 15,000 other things, then I will not be worried too much about his hyperparathyroidism. Now, whenever we are operating, our success depends upon knowing where the parathyroid gland is. So, the most successful criteria of any parathyroid surgery is the surgeon behind it, and the surgeon should know about the distribution of ectopic parathyroid glands. In today's day and age, we have moved away from the standard bilateral exploration to the minimally invasive surgery, where we direct our tissue, direct our techniques to a select area and managing it. And that is why the imaging part comes in. So first step is finding out the biochemistry. Second is finding out through ultrasound of the abdomen. So the ultrasound of the abdomen comes before the ultrasound of the neck, technically. You do an ultrasound of the abdomen to find out kidney stones. You find out the DEXA scan, there is any issues or not. You look for any of those criteria. Only after the criteria is met, only after you made that I need to operate this patient, is when it is important to look where the gland is. Okay, it is important because ectopic glands are very common. It allows a directed exploration, diminishes unnecessary dissection, and shortens operative time. If I know exactly where my gland is located, I can straight away go dissect there, remove it. I don't need to dissect around both the thyroid gutters and cause scarring there. So ultrasound will typically show a hypoechoic mass compared to a hyperechoic thyroid follicular lesion. Advantage is it is excellent in detecting parathyroid lesions near the thyroid. You can even do a needle biopsy, but what you need to do on the needle biopsy is not do an FNAC. You don't need to do a cytology on that, like we do for thyroid lesions. You will not get reliable information. You need to do PTH washout. So what you need to confirm is whether the lesion that you are seeing is a lymph node, it's a thyroid disease, thyroid condition, thyroid pathology, or a parathyroid pathology. So the needle fluid that you aspirate, you essentially send it for testing and measure the PTH levels in that testing. If the PTH levels are abnormally high, which it will not be in a lymph node, then you have your lesion. Disadvantage is it is like any other ultrasound, operator dependent, and you may miss a retrosternal, retrotracheal, deep-seated parathyroid lesion, and it is difficult to distinguish small lymph nodes from small abnormal parathyroid glands. So it's more of a structural evaluation. We have heard about the sestamibi or the mini scan. Okay, it works on the affinity of selective affinity of the technetium scan for the mitochondria rich cells. Okay, and it is selectively taken up by the heart, salivary glands, thyroid, and parathyroid adenomas. So both thyroid and parathyroid adenomas both will take up the sestimation. And in thyroids, what will happen, or rather in parathyroids, it will be taken up only by those with oxybil predominance. Now, the advantage is it can detect things which are ectopic locations, double adenomas, and otherwise you can combine a CT scan with that, like it is done here, to give you a 3D assessment and locations. It's all about localizing the disease before touching the patient. All your efforts go into surgical planning. 90% of your job is done before touching a patient, where you are able to localize where and all. Surgery for a routine thyroid surgeon is fairly straightforward. However, you don't want to take the workup lightly. However, if there are small adenomas, multi-gland disease, the systemic scan will come out to be negative. And typically, what you do is subtraction imaging. You take initially both thyroid and parathyroid uptaking. Later on, you will find uptake only in the parathyroid glands, and you subtract that and you find out where the parathyroids could be located. However, thyroid carcinoma, Hashimoto thyroiditis, multinodal goiter can also. I have In my practice, relative importance of system EV scan frankly has gone down because currently I'm using a lot of this 4D CT scans where essentially you're looking at the blood supply characteristics of the parathyroid gland. You're using a 4D, you do a plain, you do arterial, you do a venous, and then you a delayed study where if you compare, remember parathyroids are very, very, very vascular and they have a very high blood supply in the sense that the velocity of blood flow is very high. So you will have a non-contrast scan where they looks, you know, a little different on the thyroids, but they will look exactly like a lymph node. When you give an arterial cut, when you're just giving the dye and taking an arterial cut, they will look exactly like the thyroid. However, in the delayed phase, the thyroid will continue to light up, whereas they will lose contrast. So they will have a very rapid uptick and then a downtick in their imaging, whereas the thyroid will have a rapid uptick and a delayed downtick, whereas a lymph node will typically on an arterial scan will not look very enhancing and then it will have a downtick. So it's a very sensitive technique, picks up lesions very fast. And what I'm looking for, I do minimum of 2 evaluation. Even though I get a very good localization on the 4D CT scans, I will be doing an ultrasound to confirm. If I have 2 studies out of 3, out of the system maybe ultrasound or the 4D CT scan, if I have 2 studies which are concordantly showing to me that yes, it is this particular gland. So I want to find out whether it's a right gland or a left gland. And beyond that, I want to find out it's whether it's an anterior gland or so rather a superior gland or an inferior gland. Now, in my patient, the USG failed to show any disease. MIBI scan came out to be negative. We did a 4D scan, which also didn't show much. So we were worried. 67-year-old lady having so much of disease, but there is no adenoma to be seen. You know, there is no, is there a hyperplasia? So all studies have their limitations. Ultrasound being limited in their sensitivity and specificity. So we decided to go ahead for something which is not very routinely done, is something that you should know is a fluorochlorine PET imaging of parathyroids, where what we have seen is there is increased choline uptake or upregulation of choline kinase in the parathyroid adenomas. And once the drug is given and the scan is done, it has a selective uptake. So in our challenging patient, we decided to do a F-choline PET scan. And as you can see, we found a very nice uptake on the F-choline PET scan. Sorry. Now, when we did a imaging review of the 4D CT scan, we found that suspicious lesion in the mediastinum. And we were able to localize it on the system EV scan. However, there was no uptake. So our thought process was they don't have a lot of oxyphils, which are rich in mitochondria. Now, to localize the disease, we use certain landmarks. The inferior pole of thyroid, the gland was there. And then to help me during my surgery, I took the help of the innominate artery, the brachiocephalic vein, and found a lesion to be very, very close to the clavicle, just posterior to the clavicle. So a simple incision was given. There are 2 approaches. There is a front door approach where you go midlines between the strap muscles, elevate the entire thyroid gland and dissect. This is very good approach for your posterior or superior disease. And other is a trapdoor approach or a backdoor approach where you are going anterior to the sternocleidomastoid, dissecting out. You're not dividing the strap muscles in the middle, and you're going laterally, like how we do in revision cases. What is most important to know, however, is these glands are not only superior and inferior, there are anterior and posterior. And inferior glands are generally anterior to the plane of the recurrent laryngeal nerve, and the posterior. So recurrent laryngeal nerve can sometimes be a very good useful landmark if you want to identify parathyroid levels, parathyroid glands and posterior glands. And the posterior upper gland can have migration lower down. And as we have discussed, the migration pattern of inferior glands are different. They are more anterior. And that is why as they go lower, they become closer to the clavicle or closer to the bone, more superficial. This is typically the expected location of our gland. Now, when we did surgery, you can typically dissect and you will find a level or a vessel directing, and once you follow this vessel, and this is all very fine work. You will not find even RBCs when you are doing this dissection because it's all about visualizing the anatomy. If you are very crude with your dissection, everything will get stained by blood and you will not be able to identify the parathyroid gland accurately. Remember, we are looking for glands which are less than a centimeter in size. And this was about 9 millimeters. We could find it just entering the mediastinum, which we had sent for frozen section, which confirmed as a parathyroid gland. The other thing unique about parathyroid glands is they have, or parathyroid hormones have a very small half-life. So we do a parathyroid levels during the surgery. Just before the incision, it was 210, and within 5 minutes of removing the gland, we could find that the level to drop to 63. So what is our criteria for success? How do we know that only one gland is important or one gland is essentially responsible and the other three glands are not problematic? How can minimally invasive parathyroid surgery be successful? Is when we remove one gland and there is a drop which is more than 50% and also in the normal zone. Remember, I told you 10 to 65 is normal. So it should be more than 50% drop within normal zone, especially to rule out multi-gland disease. About 3 to 4%, up to 5% may have, but if I have concordant imaging, then I am very certain that the chances of that is almost negligible. However, this was a scenario where I did one of my cases where there was initially high parathyroid levels, which because of manipulation hormone levels went up. We removed first gland, the levels didn't turn out to be that low. Then we went on exploring. We did a second gland surgery and the levels continued. It's only after removing the third that the levels dropped significantly. So sometimes when this surgery went on for like, almost 5.5, 6 hours. So you need to be mentally prepared to, get into this challenging condition. So in our patient post-operatively, within a day, the calcium levels dropped. Patient was started on supplemental calcium because they can develop hungry bone syndrome. And there is good amount of data that a lot of the symptoms improve, including renal stones, muscle pains, and generally failure of localization leads or bad diagnosis leads to failure after surgery. So either you have done an incorrect diagnosis or you have missed a multi-gland disease. And recurrence typically is an asynchronous multi-gland disease. At the time of operation, in which all the criteria were met, you remove the gland which was troubled, but in the inherent gland structure, so you should always counsel for about 10% recurrence rate over a period of 10 to 15 years. So the take-home message is important to have a complete diagnosis. Remember, we are diagnosticians, we are clinicians first before being surgeons. You need a team. Routinely, and I never operate any patient, even though I've been doing it for a better part of 10 years now. Okay, I am fellowship trained and all, but I never do without my endocrinologist evaluating the patient prior hand. Even though I have done the complete evaluation, still I take their clearance. I would never do that when I'm doing a thyroid surgery. If I'm doing a thyroid cancer, if I'm doing a multinodular disease, I'll involve the endocrinologist only if required in the post-op period. However, for parathyroid levels, I always do that in the pre-op setting. There's a lot of discussion that goes with my radiology team, if I'm doing a system EB scan with my nuclear medicine colleague, and in the intraoperative setting with my pathologist, and I have to keep the lab prepared for intraoperative PTH. So it's a lot of homework. And detailed localizations only after you have done the diagnosis. Don't do your ultrasound to detect hyperparathyroidism. It's a biochemical condition. Ultrasound will just tell you about the size, which has no relevance without the necessary clinical information. And one needs to have a clear surgical plan that needs to take into place, all the possibilities, and you have to discuss all of this in advance with the patient. They need to do. These are some useful articles. You may take a screenshot of this. They are free to download. This is a gold standard. Dr. Gregory Randolph was my teacher for surgery of thyroid and parathyroids. All that I've told is all from these articles and this textbook. All the information is there. for you to see. All right. Okay. Now we will go to the question answer session. Everybody, please decide if you have any questions. I just a second. I'm just trying to locate the Q&A box. Things are anybody from NBE, can you just guide me where the Q&A box will be? Anybody from NBE can guide me where the Q&A box will be?
Right bottom there is option to chat.
More options.
After add participant chat.
Share content, stop video. ये शो कैप्शंस दिखा रहा है सर वेबिनार.
Right bottom में add participant chat.
हाँ, chat. Thank you. Okay, perfect. So PHPT in pregnancy management protocol, we can't do ionizing radiation, only blood test. Yes. So Yuvraj has asked, sir, can you explain PHPT in pregnancy management protocol? See, management protocol is medical management. Unless and until so we have had a patient, I mean, it's a very rare thing. If you're finding hypercalcemia and if it is not too bad, you can really wait till the pregnancy is over. Only if the patient comes in hypercalcemic crisis. We had a scenario where a lady with 7.5 months, 8 months patient had come with hypercalcemic crisis, and for which essentially the emergency C-section was done. Even when the sectioning was done, there was a lot of, so to say, calcium deposits in the fat around the uterus. That is what the gynec colleague told me. And then subsequently, while evaluating, she had a calcium level of 13 plus. Subsequently, after she stabilized, only then the role of the surgeon comes. I mean, I was given a reference 2 weeks after she got admitted and everything was managed. Once she was stabilized, our job is pretty straightforward, is to localize the disease and go and excise it. So, I mean, it's teamwork. I don't recommend ENT surgeons to manage hypercalcemic crisis. Now, brown tumor, Dr. Monica is asking for brown tumor. Brown tumor is essentially, I would say, especially in a metro city, a very rare entity nowadays. In more so in prolonged hyperparathyroidism, where essentially a part of the bone is eaten up by prolonged osteoclastic activities. So those are brown tumors. They are essentially, bereft of their calcium levels, areas of bone which are bereft, and there is a lot of, so osteitis fibrosis cystica is something like that, we say. Calcium metabolism, I can share again. I just open up. See, calcium metabolism, if you ask from the ENT surgeon's perspective, is actually pretty straightforward. Zyada complicated na karne jaye. Always ask or think yourself as clinicians. Okay. Okay. So I hope my slide is seen to everybody. So this is the calcium metabolism. What am I concerned here? I am concerned whether I am dealing with a primary parathyroidism, hyperparathyroidism, or a secondary hyperparathyroidism. Now, calcium in the blood can be low, can be high, or can be normal. Similarly, correspondingly, so say you take a scenario where there is high calcium levels. Okay. Now I want to find out whether that high calcium levels are because of parathyroid or something else. Okay. Whenever you are deciding, look at this chart. Okay. If there is high calcium levels, let me put this. If there is high calcium levels and there is low PTH, then your parathyroid hormone has nothing to do with, your parathyroid gland has nothing to do with this issue. It is either the patient is taking a combination of calcium with vitamin D. You give anybody activated vitamin D, you get this Rocaltrol or Atrol, which is activated vitamin D. It's I think the clinical name is Rocaltriol. Uh, this activated vitamin D, you give them with calcium levels, anybody's calcium level will rise. A lot of times what happens, these patients in the post-op setting after parathyroid surgery, they start taking too much of calcium and vitamin D and they'll end up with hypercalcemia because of that. But PTH levels at that time will be low, absolutely low. Only if calcium is high, PTH should be low. They are both in kind of like indirect correlation, to inverse relation. If calcium is high and PTH is also high, that's abnormal. If calcium is high and PTH is low, if PTH is high and calcium is low, then it is nothing to do with parathyroid hormone. If PTH is high but calcium is low, then it is most likely a vitamin D deficiency or a decreased calcium intake, which is rare in CRF or vitamin D resistant rickets. Vitamin D resistant rickets are again a very rare entity and rarely end up reaching the ENT doctors. It is this that we should not miss, and we should know where our role comes into play. Sometimes patients will get tested for PTH level will be high, there will be no vitamin D testing, calcium level will appear to be normal, and you will feel like he's having normal calcium with PHPT. No. The first is vitamin D. If there is a vitamin D deficiency, then it cannot label it as PHPT primary. It is secondary. Secondary to a deficiency in the body. I hope that clears things out. And if there is a kidney issue, then the calcium sensing goes awry. There is hypercalcemia in the blood as well as tertiary hyperparathyroidism because there is CRS. But this is essentially because in our country transplant is a challenge, and renal transplant patients sometimes wait for months to years before they get a donor, and because of that, there is also a lot of ectopic parathyroid activation. So the challenge is in these patients, even if you go ahead and do the parathyroid surgery, their symptoms may become a little better, but there is ectopic parathyroids present in different parts of the body, ectopic rest of parathyroid cells, which start activated in secreting parathyroid hormone. So the real treatment for this patient is actually a renal transplant and not a parathyroidectomy. But yes, parathyroidectomy for these patients has also been described. Now, some more questions. We have some time. So, what is the management of brown tumor? You diagnose the parathyroidism, treat the parathyroidism, and supplement the patient with calcium levels. If there is any significant, junction where it's like a vertebral bone or some significant bone which is fractured or prone to collapse, then you take the orthopedic colleague in place and they'll help you fix it. But essentially, it takes about 2 years roughly for your bone mineral density scans to start showing improvement. Like if you operate someone today and he's got a T-score of minus 3.9, then it will take at least 2 years. You should wait till you are expecting any improvement in. But treatment is essentially treat the primary pathology. Now, treatment options for localized parathyroid cancer at an early stage. It's a very rare thing to have an extremely localized parathyroid cancer at an early stage. Treatment option is excision. Just a second. I'm getting. Right, sorry about that. So, I mean, the treatment of choice for parathyroid cancers is surgery, surgery, and surgery. Localized parathyroid cancer, there is no such entity. when you excise the gland, it at best may have some atypical changes, but it's very difficult for the pathologist to identify very early stage parathyroid cancers. Parathyroid cancers typically are identified as cancers only when they start invading organic tissues such as the thyroid gland. Some parathyroid patient may present with different angles of palsy, but I'll tell you, radiation. So radiation therapy is a good option only if you leave residual tissue behind, and it's a big difference. Frankly, it's a very rare condition. In my entire career of just doing parathyroid for a better part of 10 years, I have seen probably one patient with suspect parathyroid carcinoma. I'm not saying I'm a very high volume surgeon. Once close to 150 cases, but I mean it's a very rare entity. Autoimmune hypoparathyroidism, frankly, I can't tell. I know. I'll have to refer the patients to my endocrinology colleague. So I don't think we should worry about autoimmune hypoparathyroidism too much as any. It's out of the perspective of a head and neck cancer surgeon or a ear nose throat surgeon. So my endocrinology colleague is the one who will managing it. I'm sure it will not be in isolation. There will be other autoimmune conditions along with it, and you have to systematically look at the patient for that. And with that, I think we have answered all the questions. I'll be happy to connect with you guys at a later stage if the module allows us. At that time,
Good evening, Dr. Rahul. This
Yes,
is Dr. Nilima this side.
yeah, ma'am.
Yeah, I could join very late into the webinar. I'm sure it was a very informative talk, and a couple of questions you've answered. And there is one question: management of autoimmune hypoparathyroidism.
Yeah, madam. So I told for that I think that is in the domain of the endocrinologist. I don't think it's in the domain of an ENT doctor. So
Yeah.
we'll take out autoimmune hypoparathyroidism.
Yeah, and I think the rest of the things like the management, the surgery part, and we will be discussing in the next talk, which is about the surgical management. And I'm sure you must have touched upon the systemicity scan and the other investigations.
Yes, yes.
Sure. So,
Thank you so much.
if there are no other questions, yeah, I think.
Thank you all training faculty members for joining this session.
Yeah, so we will conclude over here. Thank you, Dr. Rahul, for participating and
Thank you, madam. Thank you.